Tibia. In this video, you will learn the main anatomical features of the tibia, its borders, surfaces, and ends, important muscle and ligament attachments, the ossification process of the tibia, key clinical anatomy, including common fractures and surgical relevance. Let's begin our detailed study of the tibia. The tibia is the medial and larger bone of the leg. Side determination, the upper end, is much larger than the lower end. The medial side of the lower end projects downwards beyond the rest of the bone. The projection is called the medial malleolus. The anterior border of the shaft is most prominent and crest-like. It is sinuously curved and terminates below at the anterior border of the medial malleolus. Features: the tibia has an upper end, a shaft, and a lower end. Upper end. The upper end of the tibia is markedly expanded from side to side to form two large condyles, which overhang the posterior surface of the shaft. The upper end includes a medial condyle, a lateral condyle, an intercondylar area, and a tuberosity. Medial condyle is larger than the lateral condyle. Its superior surface articulates with the medial condyle of the femur. The articular surface is oval, and its long axis is anteroposterior. The central part of the surface is slightly concave and comes into direct contact with the femoral condyle, lateral condyle. The lateral condyle overhangs the shaft more than the medial condyle. The superior surface of the condyle articulates with the lateral condyle of the femur. The articular surface is nearly circular. The articular surface has a raised medial margin, which covers the lateral intercondylar tubercle. The postero-inferior aspect of the lateral condyle articulates with fibula. Intercondylar area. The intercondylar area is roughened area on the superior surface of the two condyles. The part is elevated to form intercondylar eminences, which is flanked by the medial and lateral intercondylar tubercles. Tuberosity of the tibia. Tuberosity of the tibia is the prominence located on the anterior aspect of the upper end of the tibia. It forms the anterior limits of the intercondylar area. Inferiorly, it is continuous with anterior border of the shaft. The tuberosity is divided into an upper smooth area and the lower rough area. Shaft. The shaft of the tibia is prismoid in shape. It has three borders: anterior, medial, and interosseous, and three surfaces: lateral, medial, and posterior. Borders. The anterior border is sharp and S-shaped, being convex medially in the upper part and convex laterally in the lower part. It extends from the tibial tuberosity above to the anterior border of the medial malleolus below. It is subcutaneous and forms the shin. The medial border is rounded. It extends from the medial condyle above to the posterior border of the medial malleolus below. The interosseous or lateral border extends from the lateral condyle a little below and in front of the fibular facet to the anterior border of the fibular notch. Surfaces. The lateral surface lies between the anterior and interosseous borders. In its upper 3/4, it is concave and is directed laterally, and in its lower 1/4, it is directed forwards. The medial surface lies between the anterior and medial borders. It is broad, and most of it is subcutaneous. The posterior surface lies between the medial and interosseous borders. It is widest in its upper part. This part is crossed obliquely by a rough ridge called soleal line. The soleal line begins just behind the fibular facet, runs downwards and medially, and terminates by joining the medial border at the junction of its upper and middle thirds. The lower end of the tibia is slightly expanded. It has 5 surfaces. Medially, it is prolonged downwards as the medial malleolus. The anterior surface of the lower end has an upper smooth part and a lower rough and grooved part. The medial surface is subcutaneous and is continuous with the medial surface of the medial malleolus. The lateral aspect of the lower end presents a triangular fibular notch to which the lower end of the fibula is attached. Attachments on the tibia, attachments on the medial condyle. The semimembranosus is inserted into the groove on the posterior surface. The capsular ligament of the knee joint is attached to the upper border, which also gives attachment to the deeper fibers of the tibial collateral ligament. The medial patellar retinaculum is attached to the anterior surface. Attachments on lateral condyle on the intercondylar area. The iliotibial tract is attached to the flattened impression on the anterior surface. The groove on the posterior surface of the lateral condyle is occupied by the tendon of the popliteus. Tibiofibular joint is attached around the margins of the fibular facet, attachment to the intercondylar area on superior surface. The following are attached from before backwards. The anterior horn of the medial meniscus, just in front of the medial articular surface. The anterior cruciate ligament on a smooth area just behind the previous attachment. The anterior horn of the lateral meniscus, to condyle near the fibular facet. The front of the intercondylar eminence and lateral to the anterior cruciate ligament. The posterior horn of the lateral meniscus, to popliteus with a bursa intervening. The posterior slope of the intercondylar eminence. The posterior horn of the medial meniscus, to the depression behind the base of the medial intercondylar tubercle, attachment on tibial tuberosity. The ligamentum patelli is attached to the upper smooth part of the tibial tuberosity. The lower rough area of the tuberosity is subcutaneous, attachment on the shaft. The tibialis anterior arises from the upper 2/3 or less of the lateral surface. The upper part of the medial surface receives the insertions of the sartorius, the gracilis, and the semitendinosus from before backwards, along the media border. The soleus arises from the soleal line. The soleal line also gives attachment to the fascia covering the soleus. The medial area of the posterior surface below the soleal line gives origin to the flexor digitorum longus, while the lateral area gives origin to the tibialis posterior. The anterior border of the tibia gives attachment to the deep fascia of the leg and, in its lower part, to the superior extensor retinaculum. The rough upper part of the fibular notch gives attachment to the interosseous tibiofibular ligament. The lower end, the capsular ligament of the ankle joint, is attached to the lower end along the margins of the articular surface. The deltoid ligament of the ankle joint is attached to the lower border of the medial malleolus. Blood supply. The nutrient artery to the tibia is the largest nutrient artery in the body. It is a branch of the posterior tibial artery, which enters the bone on its posterior surface. Ossification. The tibia ossifies from one primary and two secondary centers. The primary center appears in the shaft during the 7th week of intrauterine life. A secondary center for the upper end appears just before birth and fuses with the shaft at 16 to 18 years. The upper epiphysis usually includes the tibial tuberosity. A secondary center for the lower end appears during the 1st year, forms the medial malleolus by the 7th year, and fuses with the shaft by 15 to 17 years. Clinical anatomy. The upper end of the tibia is one of the commonest sites for acute osteomyelitis. The knee joint remains safe because the capsule is attached near the articular margins of the tibia, proximal to the epiphyseal line. The tibia is commonly fractured at the junction of the upper 2/3 and the lower 1/3 of the shaft, as the shaft is most slender here. Such fractures may unite slowly or may not unite at all, as the blood supply to this part of the bone is poor. Sometimes a surgeon takes a piece of bone from the part of the body and uses it to repair a defect in some other bone, called a bone graft. For this purpose, pieces of bone are easily obtained from the subcutaneous medial aspect of the tibia. That's the tibia. Strong, vital, and essential for movement. Thanks for watching.